Welcome everyone, and this is the third educational webinar organized by UAG, and it's about COVID-19 and digestive health. We believe that was mandatory to recap what we have learned and what we are still learning about COVID-19 pandemic, and for doing that, we asked two main speakers who contributed a lot to COVID-19 literature in the last 15, 16 months to join us and to give two lectures about the clinical impact of COVID-19 and also the endoscopic impact related also to endoscopic activity about the value and the role this infection had in our life. We will start with the first speaker. The first speaker is Professor Giovanni Barbara. He's Professor of Internal Medicine at the University of Bologna. He's the past president of European Society of Gastroenterology Motility, member of Rome Committee, and one of the biggest experts worldwide in functional gastrointestinal disorder or brain-gut axis disorders. And Giovanni will talk us about the clinical impact of COVID-19 in gastroenterology. Please, Giovanni.
Edoardo, many thanks for the kind introduction, and I would like to thank also UEG for the invitation tonight. What I'm going to do is to make an overview about acute and post-acute GI manifestation of COVID-19, starting from the beginning. And probably everything started sometime in 2019 in China, in Wuhan, with these atypical pneumonias that initially were not understood. And later on, it was discovered that it was a virus, a new coronavirus, SARS-CoV-2 virus. And probably this is a zoonosis. Everybody thinks that most likely everything started from bats, and probably there is also an intermediate host before the virus gets to humans, which is the pangolin. The pangolin is known in Asia and in China in particular for its skin that is used to make shoes and belts, but also probably the most important reason why the pangolin is famous is because it has aphrodisiac properties, and people eat these small mammals, unfortunately. And the reason why it was thought that basically it was a zoonosis started in the Wuhan fish market is because if you look at this scheme, you see that most of the people that were admitted at the hospital in Wuhan were either in contact with people that were at the market in the days before or were at the market themselves. So this started a new era in the infectious disease scenario with this severe acute respiratory syndrome coronavirus 2, which is a beta coronavirus, single-stranded RNA virus with a diameter of 80 to 120 nanometers. And at electron microscopy, it has an appearance of a crown, and that's the name of corona comes from. And look at the shape of the virus, and particularly focus your attention on the spike protein, which is very important for the infection. As a matter of fact, the spike protein gets in contact with receptors on the epithelium of the lung, particularly the ACE2 angiotensin converting enzyme 2 receptors, together with a serine protease receptor, which helps the virus to get into the cells and infect the cells. There is a direct cytotoxic effect of the virus, but also other mechanisms, particularly the interaction with the angiotensin converting system that is dysregulated by the virus, and this changes many things, providing some some metabolites of angiotensin that have a pathogenic effect. Also, there is an effect on the endothelium and also changes in the blood coagulation, and this speaks in favor of all the events that have been described associated with this syndrome related to thrombosis and embolism. Finally, there is also a dysregulation of the immune response that is seen in infected patients. If you look at this heat map, you see that the presence of SARS-CoV-2 RNA in infected people is not only in the lung, but also in many other organs, the kidney, the liver, brain, and blood. And this is obviously related to a systemic rather than a pulmonary type of infection. And as a matter of fact, this condition is associated with many systemic manifestations: neurologic, renal, hepatic, gastrointestinal, and we will talk about this more in detail, as well as other changes that you are well aware of. ACE2 receptors and the serine protease receptors are co-expressed in the gastrointestinal tract. Not very much in the upper gastrointestinal tract, but if we go down in the small intestinal tract, particularly in the ileum and in the proximal colon, the expression of ACE2 and serine protease receptors is very abundant. And this speaks in favor of the infectivity of the virus in the gastrointestinal tract. Also, if you take samples from the feces of patients infected with the coronavirus, then you will see that many of these people excrete the virus in the fecal matter, and the detection rate is higher in females, in symptomatic patients, and in severe versus mild forms of the disease. And the peculiar findings that we learned over time is that there is fecal shedding that is present in subjects even if there is no evidence of lung disease. And also fecal shedding can persist long after recovery in patients that have negative oropharyngeal swabs. So this has raised the hypothesis that there could be an orofecal route of transmission of SARS-CoV-2. What about the pathophysiology of gastrointestinal manifestations? We will start from the lumen. There are several papers now that describe changes in the gut microbiota in patients with SARS-CoV-2 infection, and in particular, a reduction in the so-called symbionts, the good bacteria, particularly Faecalibacterium prausnitzii, Rosburgia, and other group of bacteria, and an increase in opportunistic pathogens. And this could be related also to the symptoms and the persistence of the symptoms over time. We will talk a little bit about this later on. Also, there is evidence that fecal samples that have high copies of SARS-CoV-2 harbor higher abundance of opportunistic pathogens. So those patients that are more severely affected have more profound changes in the gut microbiota. If we look at the mucosa, I would say that most patients don't have many changes in the gastrointestinal tract, even if they are symptomatic. However, some endoscopy reports showed that there could be severe changes in the mucosa associated to SARS-CoV-2 infection in the upper gastrointestinal tract, ulcers, but also in the lower gastrointestinal tract, acute colitis, as well as ischemic colitis. What about the epithelium in the gastrointestinal tract? Plasma citrulline is an indicator of the health of the epithelium. And if you have low citrulline levels, then this means that you may have a damage in the epithelium, and those patients that had low citrulline levels had more inflammatory response, systemic inflammatory response, including CRP, but also interleukin-6, and there is an inverse correlation between CRP and citrulline in this particular study. Is there intestinal inflammation in the patients that are infected? Probably yes. This is fecal calprotectin in infected patients, and also in patients that were previously infected with the virus and now asymptomatic compared to those that were not infected with the virus. And also there is an almost linear correlation between fecal calprotectin and systemic inflammation as measured with the interleukin-6. Another aspect that probably links to the physiology of the gut, and particularly to diarrhea, which is the most prominent symptom in these patients, is levels of serotonin. If you look at this data, in critical patients infected with the SARS-CoV-2, there is a high production of serotonin that is measured in the plasma of these patients. And also in patients with diarrhea, the level of serotonin is much higher than those infected without diarrhea. And this probably is a mechanism through which diarrhea occurs. Also, the virus can infect the enteric nervous system, and this is a paper that was published recently and reviewed by us in a recent publication. And the enteric nervous system can express both the ACE2 receptors as well as the serine protease receptors. So this could be a port, a door through which the virus accesses the enteric nervous system and can also travel through the nerves to the brain. So, given the fact that the virus can infect the gastrointestinal tract, this could be linked to the manifestations that we see in these patients, not only in the gastrointestinal tract, but also in the liver and in manifestations that link the central nervous system and the peripheral nervous system. Diarrhea is probably the most frequent complaint in infected patients. However, if we look at the literature, there is a wide range of this symptom from 2% in some series up to 50% in other series. And probably this is linked to the way the symptoms were collected in the different studies, probably using not very well prepared questionnaires and many other pitfalls in this literature, including lack of definition, lack of controls, and the fact that most of the study did not exclude the patients that were symptomatic before the infection. So for this reason, we started a study that was endorsed by UEG, the GI COVID-19 study, and this is an European multi-center controlled longitudinal study, and the primary aim was to assess indeed the prevalence and prognosis of GI symptoms in COVID-19 infection, and secondary aim was to evaluate the long-term consequences of COVID-19 infection in these people. 36 centers included. Here you can see the list of the centers that participated in the study. We started from 2,000, more than 2,000 hospitalized patients, and the strength of this study is twice. First of all, the patients were symptomatic before the infection were excluded from the study, and also we had a control population that were hospitalized patients without the infection. So this is unique study, not present in the literature before in this form. And these are the results. Basically, I would like to draw your attention on the upper gastrointestinal symptoms here, and the difference between controls and the infected patients is evident, particularly for nausea. Even if there are other symptoms, but these did not reach statistical significance. While nausea, it was almost double in the COVID-19 patients as compared to the controls. Lower gastrointestinal symptoms, as expected, diarrhea was the most frequent symptom, but also urgency and less constipation, of course, and less hard stools. and of course, more loose stools. And widely, I would say that the prevalence of any gastrointestinal symptom in this population was around 50%. So very common upper and lower gastrointestinal symptoms in COVID-19. Now, what happens when the infection goes away? We think that the infection could lead to long-term consequences in these patients, and this is probably in parallel to what happens in post-infection IBS. In post-infection IBS, you get an infection from Campylobacter, Shigella, Salmonella, or also viruses, and then 10% of the people can go on to develop chronic symptoms that fulfill in some instances the diagnosis for IBS. So there are basically two studies that looked at this. This is one study from Italy that was presented at DDW this year, and you can see that this is a survey at 5 months after COVID, and you see that higher proportion of patients with COVID-19 compared to non-COVID complain of abdominal pain and diarrhea. And in also looking at the fulfillment of criteria, stringent criteria for IBS, unfortunately, the data are negative. So even if these patients have symptoms, particularly diarrhea, they do not fulfill the stringent criteria from Rome for the diagnosis of IBS. What about our study? We are looking at the long-term follow-up, 1 month, 6 months, and 12 months. These are the results that are ready now, 1 month follow-up. And at 1 month, we see that there are persistent symptoms, particularly in the upper gastrointestinal tract, acid regurgitation, as well as nausea. You remember that nausea was one of the key upper gastrointestinal symptoms during the infection, and this persists for long. And even the difference between controls and infected patients is bigger in the long term. You can also use these tables to evaluate, to calculate the probability of having continuing nausea after the infection has gone, female sex, having a high body mass index, having a high C-reactive protein during the acute infection, having dyspnea during the acute infection are all predictors of a high probability of developing chronic nausea in the long term. So with this, I finish and I wrap up by saying that COVID-19 is obviously not only a pulmonary disease, is also a gastrointestinal disease as well as a systemic disease, and gastrointestinal symptoms are not trivial and must be considered very carefully when we look at the patients during acute SARS-CoV-2 infection, but also in the long run. With this, I finish and I thank you for your attention.
Thank you so much, Giovanni. And I would like to remember the attendees to make questions in the chat in order to have something to discuss with our outstanding speakers. I have a question for you, Giovanni, and you show us data about the symptomatology and also about pathophysiology. How do you explain the pathophysiology in which we know that the COVID infection enter in our body through the GI tract, mainly thanks to receptors that are more located in the lower part of the GI tract, but in the end, the symptoms are more frequently in the upper?
Yeah, this is a discrepancy that we cannot explain based on the data of pathophysiology that we have collected so far. But I think that one possible explanation, which is interesting, is the invasion, neuroinvasion of the virus, and particularly in the vagus nerve. There are data post-mortem in autopsies that show that patients have the virus in the brain, And likely, at least this is an hypothesis, but also confirmed by data in animals, likely the virus can infect the nerves and through the vagus nerves arrive in the central nervous system. And the vagus innervates quite abundantly the upper gastrointestinal tract and is known to be implicated in the pathogenesis of nausea, as well as the area postrema and the chemoreceptor trigger zone that could be infected by the virus in the central nervous system could be also one possible mechanism of persistence of nausea in these patients.
Nice. I have another question about this. The gastric involvement is not really well understood and studied in clinical practice. And you show us that mainly the symptoms are present at the beginning of the infection are mainly diarrhea and related to bowel movement, of course. But these symptoms usually appears during the hospitalization or after the hospitalization. I mean, nausea, reflux, and all the other upper GI symptoms mainly appearing after or during the hospitalization, at the end or after the hospitalization. Do you think that it's possible that the drugs that we give to the patient during the, since these patients are highly treated with several treatments, including steroids, including antibiotics, including hydroxychloroquine. It depends, of course, of the protocol of treatment in the country. Is it possible that these drugs are inducing this effect not only in the short term, which means during hospitalization and after death, but also potentially in the mid-term and in the long term, causing post-functional disorder?
I knew you were going to ask a nasty question, and
sorry for that.
The question is very well posed, and the point is very well taken, because of course these patients are treated with all the drugs that you mentioned, and we are doing multivariate analysis to exclude the possibility that there are confounding factors related to therapies. And at first sight to this data, it seems that at least antibiotics are not a confounding factor, because also in the control population we had many patients matched by age and gender that were also taking a lot of antibiotics and other drugs for many different reasons. So it could be that this is not the entire explanation why the patients get the acute symptoms. And also, if you look at the data in non-hospitalized patients, and also if you look at the onset of gastrointestinal symptoms, you will see that the onset is quite rapid before the treatment, and also non-hospitalized patients that don't get as much treatment for the infection also have gastrointestinal complaints. So I think that there is a direct effect of the virus on the gastrointestinal tract, probably confounded by some of the drugs that we use, but not entirely explainable by the use of these medications.
And did you check about alarm or symptoms that can predict the development of this post-COVID syndrome or the prolongation of the symptoms after recovery from the infection?
Yes, we did several analyses and found that there are predictors. Gender, female gender is one of these, a high body mass index, and also having a severe infection during the acute phase is another predictor. So I think that we can predict those who can get long COVID, it is called now, and probably we should act very early in these patients and try to do our best to correct the dysbiosis or the inflammation in the gut. There are no data about treatment, but I think that treating the patients during the acute phase for the gastrointestinal problems could prevent at least part of this wave of long COVID.
Edo, I have a question for Giovanni. Can I make a question?
Please, please.
So Giovanni, first, congratulations, beautiful lecture. So everybody knows the long COVID. So now we know there is a post-infectious syndrome with a lot of symptoms, but mostly there are symptoms coming from alteration of our psyche, and there is depression. It's well known, well described, and fatigue and whatever. You think that this can overlap a little bit the evaluation symptoms you're doing?
I think it does not overlap, but it's part of the scenario, because if you think to functional gastrointestinal disorder and also post-infection gastrointestinal disorders, psychological factors are an important part of these syndromes. So having anxiety, depression is very common in IBS, in dyspepsia, and in other symptomatologies. So I think that indeed anxiety, depression, and other central nervous system symptoms are part of the game, I think.
Okay, thanks.
Yeah, I think so. And I would like to ask you, Giovanni, some, of course, a difficult question, that is how to manage this. You already told us that there is no standard treatment for this patient, but post-COVID syndrome could be really, really problematic in some cases. I have some of them in my clinical practice, and they are really, really difficult to manage, because you don't know if these are related to the infection, were present before the infection, is a consequence of depression, anxiety, and so on. But they are really, really difficult to manage. How do you do it?
Probably symptom-based therapy, probably. Giovanni?
Yes, I agree. Symptom-based therapy is one choice, but now we have several therapies in functional gastrointestinal disorders that act on mechanisms, and I think that we should try to modify some of the basic mechanisms that underlying symptoms in functional GI disorders, but also in these people. So modulating the microbiota.
Interesting. How you modulate the microbiota? I still need the secret.
The secret, okay, the secret
Don't
is...
tell me antibiotic therapy, please.
Diet, prebiotics, probiotics,
postbiotic,
absorbable antibiotics, and fecal microbial transplantation. So we have several ways of modulating the gut microbiota now.
Giovanni, let me say, this is science, but in the practice is totally different. I'm concerned about doing all of this to these IBS patients with the long COVID, honestly.
Well, I agree with you, but if you spend most of your time with these patients, you try everything. And I can tell you that if you manage some of these basic mechanisms, then you can improve symptoms in quite a substantial proportion of the patients.
I think everybody is interested in learning how you may impact the microbiota, not only in these patients, but in patients with IBS using diet. Is it just FODMAP or it's any other suggestion?
It's complicated. It's FODMAP, but not only FODMAP. FODMAP improves symptoms, but deranges the gut microbiota. So you have to be very careful.
Exactly.
You can use prebiotics that stimulate the microbiota, but if you use too much prebiotics, you worsen the symptoms. If you use a little bit, you can improve the symptoms. So it's more than science, is a sort of art, like a painter that calibrates a little bit of this and a little bit of that. I think that there is no secret behind how to treat. Everything is written in the literature, and we are trying our best to modulate the system. They are complicated patients, particularly those with psychiatric comorbidity. and other comorbidities like gynecological and fibromyalgia and so on. But I think that if you spend some time with these patients and try to use the medication in the right way, I think that you can improve a lot the symptoms of these patients.
Thanks.
Just for us and for all other people who are attending, you are not suggesting to check for the microbiota in this patient, but just to treat them empirically, right?
Well, if we look at the outputs of the microbiota, it is difficult to understand what is going on. So we don't have a clue yet, but I think that we already, as often happens in medicine, we try to cure before we understand the pathophysiology, and the cure sometimes is a shortcut to get a result. And of course, if you look at the trials, rifaximin, probiotics, prebiotics, and what I said before, in the modulation of the gut microbiota, but also we have many other drugs modulating motility, inflammation, the serotonin system, the central nervous system. There are combinations of drugs that can improve symptoms in these patients.
And probably something that you did not mention, but I'm sure that you are using a lot in clinical practice, treating the mental problems behind this kind of disorder. So cognitive behavior therapy and in some cases where is available hypnotherapy or other alternative medicine therapy, which may be really helpful for this patient, particularly after 1 year of lockdown and isolation from all the other people around.
Of course, where available can be used, of course.
There is a nice comment in the chat that is a great lecture, Giovanni. So we consider that post-COVID syndrome is a functional disorder. This is not a nice news to know.
It's a functional virus, a functional disorder.
But I hate the term functional because it says nothing. Maybe dysfunctional disorder, not functional disorder. First of all, so terminology is important, but I call these disorders now microorganic disorders, because there are changes that can be measured today. Permeability, inflammation, changes in the nervous system, microbiota. And I think that we are not there to make a diagnosis based on these findings, but this is the future. And personalized medicine based on the main change in the structure of the gut could be the future for these patients.
Absolutely. You did well to emphasize and highlight this. Thanks, Giovanni. Thanks a lot for your wonderful lecture and for your time. And now we can pass to the next speaker. The next speaker is Professor Alessandro Repici. Is full professor at University School of Medicine in Humanitas, Milano. He's associate editor of Gastrointestinal Endoscopy. He's a member of several societies and also is author of several papers about the endoscopy, and not only endoscopy. And he was the first to publish on the impact and the role of COVID-19 in endoscopy last year. And we thank Alessandro for this and for the next lecture he will do. Please, Alessandro.
Thanks, Edoardo. So again, congratulations to Joe for the fantastic lecture, and thanks to Luigi for the invitation. So glad to be here. So I'm going to repeat a couple of concepts. Everybody knows the story, and we originally considered this a disease, a lung disease, a pulmonary disease, but as Giovanni said already, this is a truly systemic disease. And I'm not going to repeat what is the mechanism through the ACE2 receptor, but I want to reinforce the concept that since the early steps of the infection, since March of April, there have been reports and literature showing the presence of the virus in the stools. So this was suggesting a potential involvement of the gastrointestinal tract from the infection, and also a potential role in the transmission of the infection. Still, this is sort of a mystery. I don't think this is going to be reality, but there are several papers saying that probably this can be a source of infection. The important point is, Giovanni said very well, so it's a huge immune system in the GI tract, there is a huge involvement, and the viral RNA are present in stool even after negative respiratory samples in a certain amount of patients being infected by COVID. So for the gastrointestinal symptoms, I think everything has been said, and we were observing a huge amount of patients in the early stages, so we were overwhelmed. March and April 2020, Milan was the epicenter of the disease, and we were the first to observe that in about 10-15% of patients, gastrointestinal symptoms preceded the respiratory disease. So patients were coming to the emergency room just with gastrointestinal symptoms like diarrhea, bloating, nausea, and but without a single respiratory symptoms. We were just testing these patients because they were coming to the emergency room after a positive test. They all were admitted, and most of them developed a serious respiratory disease. So sometimes a certain amount of patients, there may be early diagnosis based on presence of early onset with GI symptoms. Most studies are reporting the presence of GI symptoms, some GI symptoms in up to 50% of patients. The symptoms, as already said, is diarrhea, nausea, vomiting, and abdominal discomfort. So it's important. I did my first endoscopy in a COVID-19 positive patient end of I think it was third week of February or last week of February. I don't remember well. And I think it was the last week of February. That was the very early beginning of the infection in Milano. And we got one patient admitted with bleeding, so there was an emergency endoscopy, and I was very curious. So I recorded the entire procedure, upper and lower GI. I couldn't find a single sign of specific mucosal damage related to the virus. I kept recording a lot of patients COVID positive, so I have a nice library of patients who have been scoped and being COVID positive with respiratory or GI symptoms. I could not find any specific COVID associated mucosal pattern that can tell me, okay, these findings I'm watching by endoscopy is representative of correlation with the COVID infection. You see what are the main upper endoscopy findings and the lower endoscopy findings. They are very specific. And of course, this is not only the GI tract. There is hepatobiliary system involvement, a pancreatic, potential pancreatic involvement. So there have been a couple of case report of acute pancreatitis, probably associated to COVID-19, even though it's difficult to establish the relationship between the etiopathogenesis of this pancreatitis and the timing of the infection, but there is a possible islet damage with also some metabolic consequences that have been reported in the literature. So what's happening with the pandemic? The first was a complete change in the hospital workflow and organization. So we started having the big need of changing the protective measures that we were using. And the first thing that we did, we relocated most of our physicians and fellows from GI to emergency room and to other places in order to manage patients with respiratory disease. And of course, progressively we had to reduce until shutting down the entire division of GI and endoscopy, and we were limited significantly in our endoscopy practice. Of course, since we were the first out of China reporting this pandemic in Milano, we received a call in the middle of the night. I will remember I received a call in the middle of the night by Mike Wallace, who is the editor-in-chief of Gastroenterology Endoscopy. He told me, I'm shocked of what is going on in Milano. I can see this is coming to everywhere in the world. Can you write briefly a report of what you're doing with your endoscopy practice? What is changing? What kind of protective measures are you using? Because I think this is going to be a guidance for everybody. So we wrote basically this paper in one day. So the other day the paper was ready. So I would say I have to apologize. The paper is very far from being a very good paper, but that was under the impact of the emotion and also with the feeling that we need to provide information to other colleagues on what we were doing. And we defined some rules on what to do and how to do. And it's incredible. This is one of the papers that has the highest citation in GI endoscopy in the last 5 years. It's been cited thousands of times. And what we say is that there is a central role of physical distancing and hand hygiene. So we realized hand hygiene was an issue, and we also reminded everybody how to use PPE, because PPE is a matter of wearing it and taking it off. So we try to be very careful in explaining the importance of all these measures, but also how to do this and how to decide what kind of protective measure you have to use when you're scoping patients who were COVID positive. So of course, afterwards, we spent some time trying to understand what could potentially be postponed in terms of endoscopy procedures. And after a certain time, after a couple of months, there were different opinions in high priority versus low priority. So my personal opinion has been over this long time, one and a half year, that there is a tailored patient's decision. So I think that we cannot define two big categories saying, okay, these guys, they need endoscopy, the other guys, they don't need endoscopy, because in the group of patients that you subclassify as not needing endoscopy, there may be patients with hidden symptoms of cancer or big problems. So I think it's important that we start doing some telemedicine, teleconsultation, trying to talk to the patients, understanding and discriminate those patients who may require, despite the original presentation, may require urgent endoscopy. The same happened for IBD, and so glad that Silvio Danese took the lead in this field. He's also reported nice instruction on how to manage patients with IBD. Also now we have British Society of Gastroenterology guidance, and of course they more or less they repeated what we have said before for endoscopy, plus they included the use of alternative means of disease assessment, because it's important, patients undergoing biologic therapy being continuously assessing their disease activity, so they indicated different ways to manage these patients without scoping them, and there was a significant limitation of surgery in that period. So this is another paper coming again from a Silvio team showing what is the reorganization of endoscopy practice in IBD, and I don't see many big differences from general reorganization of endoscopy. Just for those doing IBD endoscopy, may be useful to have a look to this paper. So what is the consequence of all these delay, big challenge for endoscopy is the impact on cancer. Of course, our main problem is the big killer is colorectal cancer. You know that in Europe, around 1 patient is dying every 3 minutes because of colorectal cancer. UAG is investing a lot on this topic, and so over this webinar there will be about 10 to 15 patients dying about this. This is a disaster. As has been reported in several papers, there is tons now of evidence that we are worsening by far the diagnosis of cancer and the survival of patients with colorectal cancer. This delay in the diagnosis is creating a disaster, and of course there is a huge commitment by all endoscopists, and I have a couple of slides afterwards to describe what we're doing, but I don't think that these 18 months can be easily cancelled, or we can have any positive impact on those patients who have not been screened or scoped because of symptoms. I expect a worsening of the situation in terms of numbers of patients and patient survival with colorectal cancer in the next 5 years in Europe. This has been reported not only for colorectal cancer, but for all GI cancer, of course. And this is the matter of the reduction of the endoscopic activities. And the other side of the coin is that the detection rate of endoscopy tests for cancer has reported a significant increase of patients being diagnosed with cancer, but this is because of the selective nature of the endoscopy procedure. We try to scope only patients with significant symptoms of presentation that can be suspicious for cancer. So what to do with the colorectal cancer screening? Many countries stopped the colorectal cancer screening, and this was mandatory because of the situation. And also the other point, most of the patients were very scared to come to the hospital. Also, when we started reopening of the endoscopy for screening, we received so many cancellation of the appointments, patients saying, okay, I'm fine, I have no symptoms, I just fit positive, I can take these test in another 6 to 12 months. And this interruption of the screening program for the several reasons will lead for certain to delay diagnosis with a significant increase in the risk of developing colorectal cancer at the advanced stage, and also have additional healthcare workload. I can imagine there will be more surgery, more need for chemotherapy and for radiotherapy for rectal cancer. Of course, we are going to reintroduce new list for screening colonoscopy, and it's important we define priority classes for colonoscopy in order to make sure that those patients who are at more risk of developing cancer, they are scoped first. And what can be the strategies? This is what we're doing. We change our schedule. We go more vertical and more horizontal. So what does it mean more vertical? We work longer for more hours until 8 o'clock, and we work also horizontally more because we open some lists on Saturday to make sure we can go back to some backlog of our long list. And of course there is a potential advantage in involving more and more GP in colorectal cancer screening. They have to convince the people to come back to screening. They have to convince the people that the hospital is a safe place, and also they have to help us in prioritizing patients who may have increased risk of cancer. And of course, it's important the promotion of better knowledge of guidelines for endoscopic surveillance. So I think we should not lose our time, our efforts, our resources, our physicians in doing useless surveillance colonoscopy. So it's important that everybody make full application of guidelines, strict rules, and the surveillance colonoscopy, of course, can be postponed, especially if a patient has been scoped 3 years ago, and just three tiny adenomas can be postponed to 1 or 2 years without any significant risk. So also we worked on vaccination in GI symptom, and there were a lot of questions from our patients. So after a couple of weeks, we started with vaccination. We thought it was good to answer to these questions, just writing a paper summarizing what was the evidence. So we know there is basically there is no contraindication to vaccine for any GI patients, oncology patients, IBD, chronic liver diseases. Of course, this is a very nice paper again from Silvio Danese group showing what can be the pros or the cons of the vaccination in IBD patients, but at the end the take-home message is vaccinate all IBD patients. So the general message that we have to give to everybody is vaccination is extremely helpful. Whatever is the basic disease that you have, IBD, functional, oncologic, there is no limitation. Of course, that you have to pay attention, and I think the anamnestic records, both in terms of disease and medication taken by the patient, is extremely important. But in general, if you are very careful in making an anamnesis, anamnestic records, you can select the proper vaccination schedule, the proper vaccine you want to use for your patients. So the impact was significant also on all our fellows. GIS fellows with all other fellows that have been relocated. I think the GIS societies played a very good role, and they provided a lot of educational opportunities, because most of the educational, I would say, events have been stopped for long. And also I have seen a very good impact of social media, providing a very unique massive way of providing knowledge, of sharing information, sharing videos, pictures, guidelines, beautiful articles. I've been involved in some of these social medias. I've been involved in discussion of Twitter, LinkedIn, with a lot of exchange from all over the world. There were times where people from Argentina to New Zealand were discussing over the socials about the impact of a PPE, the need of using some strategies to restart the colorectal cancer screening or whatever. So I'm so glad that people use social media in this situation. And also specifically for endoscopy, this was a very good job done by the GI Society. They provide significant resources in terms of endoscopic video libraries with full access, free access, to allow the trainees and the fellow to keep training somehow with what was available. So I was also asked with a couple of other physicians to write the first guidance for GI fellows in gastroenterology, and there was a very nice discussion because we had a physician from the Far East, from Europe, and US as well. And the final message was, at the time we wrote the paper, it's difficult to give guidance because most of our G fellows were relocated somewhere else. But we recognized first that the reduction in volume of endoscopic procedure could have been a big challenge for our fellows. So we need to work to make sure that they can put in the condition to do all the procedures they have to complete within their training period. And of course, I think we have to rebuild somehow our approach to them. We need to speed up their education and their training in endoscopy. They have to offer additional opportunities compared with before. Probably we have to change the way we're training our fellows in GI endoscopy, because we need to go very fast, especially for those who have been impacted significantly being relocated in other services. So my final remarks. So first, thanks God that we are all here. This is a great message, because the challenge was big. I will remember end of March 2020, going back home and leaving the hospital. It was low light, nobody in the hospital, a lot of silence, meeting a few people saying, oh, you know, that oncologist has COVID, he died, that oncologist is positive, that gastroenterologist, that surgeon, that nurses, that person from administration. Was crazy. I was personally impacted. They touched me so much. So we were able to respond with extraordinary measures. So we should be glad of what we did. And I think for the future, we need to keep going. I don't think that we are at the end. There will be still some hard time a little bit. We have a much better knowledge. We have a vaccination. We have a powerful amount of information that we can apply to next month, to whatever is coming. But in general, I think that this pandemic will become an extraordinary opportunity for all of us to remodel and reorganize our medical practice in GI. So thank you for your attention.
Thanks a lot, Alessandro. Great lecture. You covered almost all the aspects related to COVID, from endoscopy to IBD to teaching and learning. Really, really great lecture. And first of all, I have a comment. Probably you believe to have done your first endoscopy in COVID positive patient end of February, but probably you did more 1 month before that. Just to know.
The paper was published online March 1st.
Yeah. But you mentioned that you did your first endoscopy end of February, but probably you did know that other patient who you endoscopy.
Sure, for sure.
In January or December, it was a joke, of course. Yeah. And there is a question from the audience: is there a role for video capsule endoscopy for CRC screening?
Very good point. So I know that NHS in UK, they started doing this. I think it's a good opportunity. Just make sure that you do properly. This means having a completely different bowel prep schedule as compared with standard colonoscopy. So you cannot do capsule colonoscopy with the standard bowel prep. You need to put a lot of attention on that, otherwise you are wasting your money because the capsule is not seeing anything. But I think it's a great opportunity.
Great, I think so. And I was impressed by the rate of cancer that we lost because of COVID infections. Almost 80% in UK in 1 year. I mean, how long does will take for being impaired?
So I think we have two problems. One is this one, but the other one is the forecast of cancer incidence, colorectal cancer incidence in Europe, or I would say overall in Western countries. So if you look to the EU forecast, European Union, European Community, the forecast is that for the next 5 to 8 years, the most populated European countries will have an increase in colorectal cancer incidence, despite most of the countries they have a fully adopted screening program. So this is a problem. And on top of this, there is the delay of these 18 months. I would say 24 months, because still there are countries or regions or cities that did not start with a screening program. So this will create probably 10 years long consequence in terms of incidence of cancer, staging of cancer, mortality of cancer, and the resources of healthcare to be used, because we will spend a lot of money more as compared with the pre-COVID time.
May I ask a question to Alessandro? You talked about the people that are worried to come to the hospital and to the endoscopy because they are worried about being infected in hospitals. And this has been also the case in our hospital. And we canceled many endoscopies, even if we started again and tried to catch up what we lost. And what will be the long-term impact of this also in the future? Because we also see in these days that the prevalence of COVID infection is very low, that people don't want to come to endoscopy.
So I have a bad comment on this. So the good comment is patients, they understand much better now. They are more quiet. We see, at least here in Milano, here in my hospital, we do very high volume procedure. We have 7 rooms running, so we do more than 15,000 patients every year. So my feeling is this going back. So all patients now, they want to be treated. I must say that physicians, they have to understand they have to work much more. This is my bad comment. Still, we need to change our attitude. We have to work much more in terms of hours dedicated to endoscopy to provide a safety approach to our patients, because we need more time for patients to turnover. We need social distancing with hand hygiene. We need to change our protective measures all the time for every patient. So this is requiring, you cannot do the same number of patients in the same time you did pre-COVID. This requires a commitment from ourselves. I see that in at least in few cases, I have not seen that commitment. I hope everybody is fully committed to this. Otherwise, we will increase the number of cancers.
Yeah.
I
also think that this needs a big effort in terms of personnel and people that should be hired in hospital from now on, because even the cleaning of the rooms requires a huge number of people.
Yeah, but Giovanni, what is different from before, that the whole hospital, public, private, they have a huge amount of resources for that.
Yeah.
And the recovery fund will bring additional resources.
Exactly.
So now there is no problem of money. Now the problem is ourselves. So we need to use the money properly, because there is space for improving that.
Quickly, I would say, because the procedure.
Absolutely, you're right. You're totally right.
To recruit people in hospitals are very, very slow. This is what happened. We did the entire COVID period with very, very few people, and it was very tough, I can tell you. And then some new, employments and some new people came in. But for a long time, because of bureaucratic reasons, I think that there was a slowdown in this process of recruitment.
I see there is a provocative comment in the chat, Alessandro. Should we arrive to a 24-hour endoscopy service?
So my answer to this provocative question is whatever it takes. Whatever it takes. Absolutely, whatever it takes for our patients. This is extraordinary time. We need extraordinary effort. Restless. Whatever it takes. No doubts on that.
Yeah. But we have also to keep some time for us.
Next year.
And Giovanni, do you want to say something?
My comment is that endoscopy and the screening of colorectal cancer, you showed very nicely that got a very bad, effect of COVID. I was wondering if you know the data about other type of cancer and other screenings, because I think that this situation is similar also for other cancers.
Yeah, but the impact of non-GI cancer has been a little bit less, because endoscopy has been regarded immediately as a potential source of infection because of the oral route, of the coughing, the droplets. So they stopped the endoscopy earlier than the other method of screening, for example, for breast cancer, no? And they prolonged this for longer because of the risk of the endoscopy itself. So I think there will be an impact also in other cancer out of GI, but not as big as the GI cancers.
Probably the ENT specialists had the same impact as us,
yeah,
or probably more. I think that we are we have to close this webinar, and of course I want to thank again Alessandro and Giovanni for their wonderful lecture, and I have to finish. Remember to our audience that there will be another webinar scheduled on July on acute pancreatitis, and another one will be done in autumn about virtual clinic. And there will be also some upcoming podcasts in the next future, one held by Fernando Magro and Candida Beu, and another one with Marcus Hollenbach about pancreas. And again, thanks, Alessandro, another one about endoscopy. So thank you to our speaker. And
thank you, everybody, guys.
Thank you. It was a pleasure.